Hello, this is Dr. Gay from First Look MRI, and this is a 72-year-old patient who had a soft tissue mass in their finger, their distal third finger right here. On the x-ray we do not see any bone destruction or erosion, and we do see a lytic process here in the base of the proximal phalanx of the index finger. They did have a little bit of pain. They thought maybe related to this, and on the x-rays here we see that the lesion is expansile. There's no cortical breakthrough, no bone destruction. And on the MRI scan here we have a T1 weighted sequence. We see that here's the index finger looking at a sagittal T1 image. The lesion has really sharply defined lobulated margins. There's no evidence of pathologic fracture, no bone destruction. They have some fatty marrow centrally, so this looks like a non-aggressive bone lesion. See how sharply defined the margins are here. There's no marrow edema, so definitely a non-aggressive bone lesion. And when you see one of these in a finger, especially the proximal phalanx, think about an enchondroma. They're very common here, and again, most common in the proximal phalanges, then the middle, and then the distal phalanges. And unlike elsewhere, like in the knee or other places where you have the speckled, mottled calcification centrally, this doesn't have the calcification, and so on x-rays it just looks like a lytic bone lesion like we see here. So classic finding of an enchondroma in this patient. Now we're going to look here distally, and on the third digit we really don't see anything on the sagittal view because interestingly that susceptibility artifact goes right across here, and they have a lesion right here. You just can't see it. But if we put up some axial images through this, we see this lesion right here. This is the distal phalanx of the middle finger, and look at this area that's homogeneous and intermediate to low T1 signal intensity. It touches the periosteum here. It's confined to the soft tissues. There's no bone erosion, no marrow edema. This is a T2 weighted sequence. We see the margins are really well defined. It looks very rounded, very homogeneous, hyperintense T2 signal intensity within. This is a coronal T1 image. We just see it on one slice, but right here is the lesion. So there are two main things this could be. Number one, this could be an epidermal inclusion cyst. I think that's what it is, just because it's so uniform, and they have the susceptibility artifact from the adjacent digit here. So they've had an injury before, so it may be an epidermal inclusion cyst, where dermal elements get introduced into the soft tissues and it grows into a cyst. The other thing this could be is a giant cell tumor of tendon sheath. They can look just like this. A lot of times they touch the palmar surface, the distal tendon sheath there, and they can look exactly like this. They can be really hyperintense in the T2 sequence just like this as well. So in this case I would mention both. But that's it. Thank you very much.